Hello. Namaskar, Jai Hind. Welcome all of you. I am Dr. Narinder Taneja from Bhiwani. I am chairperson of this session. Dr. Alka Jha, Dr. Goswami, sir, please come forward. Dr. Ashwini Kumar, अभी दिखे तो थे? हाँ ठीक है सर, ठीक है. Dr. Sumit Grover, Dr. Mandar Pranspe. No. So we are going to start today's session. Dr. B.N.R. Subudhi, he is busy somewhere. Is Dr. Rahul Deshpande here? Dr. Rahul Deshpande? आप सर अपने प्रेजेंट करिए सर. आपका है सर आज? एक मिनट सर, एक मिनट. हाँ बैठिए सर, यहाँ पे को कन्वीनर डॉक्टर सुमित ग्रोवर, डॉक्टर राम कुमार जायसवाल. सर आइए प्लीज प्रेजेंट योर टॉपिक.
नहीं इधर नहीं Good afternoon. I myself Dr. Ram Kumar Jaiswal, Professor and HOD, Ophthalmology, BRD Medical College, Gorakhpur. My topic is prevalence of refractive error induced amblyopia presented in a tertiary care teaching hospital. Childhood visual impairment due to the uncorrected refractive error is one of the most common problem in school age children and is the second leading cause of treatable blindness. Uncorrected refractive errors are responsible for up to 40% of the cases of the visual impairment worldwide and remain prevalent even in high income countries. Approximately 12.8% million children in the age group 5 to 15 or 16 years are visually impaired from uncorrected or inadequately corrected refractive errors, estimating a global prevalence of 0.96%. And anisometropia must be addressed to prevent development of the amblyopia. The material methods is the present study is descriptive cross-sectional conducted from July 21 to July 22 in a tertiary care center. Patients were divided in 4 age groups, that is 5 to 7 years, 8 to 10 years, 11 to 13 years, 14 to 16 years. A thorough history was taken regarding asthenopic symptoms, previous history of ocular diseases, including history of the wearing of the glasses. The children were then enrolled after taking consents from the parents and underwent visual acuity assessment, objective diffraction using autorefractometer followed by cyclopentolate 1% cycloplegic stick retinoscopy. These children were then categorized according to the type of refractive error after post-mediatic examinations. The inclusion criteria is children between 5 to 16 years of age diagnosed with refractive errors. Exclusion criteria is children of the less than 5 years of age and the children having any other associated disease of ocular structures. The C-square test was used to analyze differences in the refractive errors. This table shows the distribution of children according to age. In between the 5 to 7 years, that is 17.9%, 8 to 10 years, 21.2%, 11 to 13 years, 26%, and the highest is in the age group of the 14 to 16 years, 34.9%. And this table shows distribution of children according to the sex. In the male, this is the 54%, and in female, this is 46%. And this shows the distribution of children according to the visual acuity. In the 6 by 6, UCVA is 79%, while BCVA about 96.9%. In 6 by 9 to 6 by 12 group, UCVA 13.3% and the BCVA 2.5%. In 1618 to 660 is UCVA 5.3% and the BCVA 0.5%, and less than 660 in the UCVA 2.4% and the BCVA 0.1%. This table shows prevalence of refractive error by the age. In age group 5 to 7, the percentage is 18%, 8 to 10%. In age group 8 to 10, this is 19.1%. In age group 11 to 13, this is 21.5%. And age group 14 to 16, this is 13.4%. That is the highest percentage. This table shows prevalence of refractive errors by the sex. In the male, this is 19.1%, female 16.4%. And this shows the association of age to the refractive errors. In age group 5 to 7 years, simple myopia 1.8%, simple hypermetropia 9.8%, myopic astigmatism 0.5%, hypermetropic astigmatism 1.5%, mixed astigmatism 4.4%. In age group 8 to 10, this is simple myopia 8.3, simple hypermetropia 8.8, myopic astigmatism 1.4, hypermetropic astigmatism 1%, and the mixed astigmatism 3.3. In the age group of 11 to 13, simple myopia 18.6, simple hypermetropia 7.7, myopic astigmatism 2.1, hypermetropic astigmatism 0.5, while mixed astigmatism 2.3. In the age group 14 to 16, that is simple myopia is highest in the 25.8%, simple hypermetropia 1.5%, myopic astigmatism 2.3, while hypermetropia 0 and mixed astigmatism 0.8%. And this table, this graph shows myopia increase with the age and the hypermetropia decrease with the age group. And this table shows association of sex to the refractive errors. Males in the simple myopia 26%, simple hypermetropia 20.3%, myopic astigmatism 3.1, hypermetropic astigmatism 1.8, mixed astigmatism 5.2%, while in the female group, the simple myopia 19.3, simple hypermetropia 14.7, myopic astigmatism 2.6, hypermetropic astigmatism 1.3, while mixed astigmatism 5.7. Discussion: the prevalence of the refractive error in this study was 17.9%, which was much higher when compared to the other observed by the GVS Murthy et al., nearly 6.4%, while similar study from different parts of the world showed a prevalence of 8.2% in Baltimore, USA, and the 12.8% in Sunni district in China, 2.9% in Nepal, 15.8% in Chile. There was a significant difference in the prevalence of refractive error with advancing age from 18 to 30.4%. Our results were comparable with the study conducted by Varal et al. In Devangiri. A study conducted in the Ahmedabad city showed that the prevalence of refractive error was highest 40% in the 16 years old. There was no significant difference in the prevalence of refractive error between the males and females in our study. This was similar to the result shown by Ande Veer et al. In Andhra Pradesh and Krishnan B.M. et al. In Vilupuram, Puducherry, where no sex predilection refractive error was noted. Hassan et al. Was found that myopia 63.5% was the most common type of refractive error, followed by hypermetropia, astigmatism, which is similar to the result of our study. There was no significant difference in the prevalence of myopia, hypermetropia, and astigmatism between the males and females in our study, similar to the study conducted in the Vilupuram, Puducherry. In our study, 68, that is 3.1% students suffered from myopia. It was common in children with visual acuity between 6 by 9 to 6 by 12, which is similar to the study by the Menon et al. Conducted in the RP Center in the AIMS. Conclusion take-home message is that amblyopia is one of the most common cause of impairment in the both children and adults, with a prevalence varying between 0.2% and 12% depending on the subset of the population studied. Severe amblyopia is also considered a significant risk factor for blindness in case an individual loses sight in the fellow eye. Amblyopia increases the chances of blindness in the healthy eye, mostly from the trauma. Timely diagnosis and treatment is likely to reduce the prevalence of amblyopia, as has been seen in many countries that have taken up mass education. Visual screening as important community aids to increase knowledge and awareness about the condition. Thank you.
Thank you, Jai Shival. Our next presentation will be, we are just slightly changing the schedule. Next presentation will be by Dr. Professor Narendra Kumar Taneja. You know Dr. Taneja that he is relentlessly working on the vaccination since COVID time and before that also. So I invite Dr. Taneja to speak on his topic, adult vaccination.
Thank you, sir. Thank you, All India Ophthalmological Society, for providing me opportunity to present this topic. ये एक मिनट चलाना, आगे कैसे हो नहीं रहा है, नीचे करना ऊपर करना. I have no commercial interest. Trade names have been given only for the sake of convenience. So I will discuss vaccinations to prevent vaccine-preventable diseases. Topic which is of importance to all of us, to all our family members, and all our neighborhoods. Pneumococcal vaccine. There are two types of pneumococcal vaccines. One is called pneumococcal polysaccharide vaccine. This is a short-acting vaccine, and this is T-cell independent, means does not give immunity as by cytotoxic cells. Pneumococcal conjugate vaccine, or PCV. This is a long-acting vaccine and gives mucosal immunity. There are 4 types of vaccines, 10, 13, 15 and 20 valent. PCV13 has been the commonest available so far by the name of Prevnar. Only one injection is given throughout life. However, whenever the Prevnar 20 becomes available, this can be given. In normal persons, see all of us, if we are above 40, don't have any comorbidity, we should get 1 dose of this vaccine. And if a person is below 50 but with certain immune conditions where immunity is compromised, like nephrotic syndrome, chronic kidney disease, chronic steroid use, cancer patients, their PCV13 is given 1 dose and followed by 2 doses of PPSV23 after 8 weeks and 5 years. PCV10 is used in children only, up to 2 years of age, Synflorix and Pneumocil. PCV15 is being developed by the Serum Institute of India. This is the picture of injection Prevnar 13. PPSV23, this has 23 different strains of the pneumococci. Immunity lasts 5 to 10 years. Person with normal comorbidities, they are given single dose between 19 to 50 years. But if they are immune compromised, PCV is given first, then 2 doses of these vaccines. And 1 dose is reserved for persons above the age of 65 years. So if we are above 65, we should get this vaccine. But before that, get PCV13. Cost of this vaccine is about 2100. Coming to flu and typhoid vaccines. These 2 vaccines, the doses are same for children, small children 6 months of age, and adults. Flu vaccine is given every year to adults with comorbidities, to pregnant ladies and all healthcare workers. They should get it. Cost about rupees 2000, except Vaxiflu made by Zydus, 1600 rupees. Typhoid conjugate vaccine, this is the most cost-effective vaccine because only 1 vaccine is given throughout life. If you have been given in childhood, there is no need of this vaccine. 6 months to 45 years, half ml intramuscular. This can be given to persons above the age of 45 also. Cost about rupees 2000. Measles, mumps and rubella. This is of importance to ophthalmologists also because we want to prevent congenital rubella syndrome. So MMR contains measles, mumps, rubella. MR contains measles and rubella. RVAC contains only rubella. So this is given in the preconception period to young girls and to adolescent girls. However, pregnancy should be avoided for 1 month. But as a healthcare workers, we should get 2 doses of these vaccines and this can be used till the age of 60 years. The cost of pre-filled vaccine is about 600 and 700. Hepatitis A. There are two types of vaccines to prevent hepatitis A. One is killed vaccine by the name of Havrix. 2 doses are given at 6 to 12 months interval. In children, 0.5 ml is used, and for adults, 1 ml is used. However, live attenuated vaccine, a single dose is required. Same dose, 0.5 ml for children as well as for adults. Available by the name of BioVac A, rupees 1600 only. Whereas Havrix cost about rupees 2000, and Havrix 1441 ml is not available. So two injections can be combined for adults. All doctors, they should get this vaccine. Immune compromised persons, only killed vaccine should be used. Hepatitis B, 3 doses are given 0, 1 and 6 months if not given in childhood. In adults, dose is 1 ml, in children it is 0.5 ml. Boosters are not recommended routinely. One can get antibody level checked. If the IgG level is less than 10, then one can go for booster. Or if a person is above 40 without going for these IgG levels, they can get a booster. When coming to chickenpox or varicella vaccine, this is a live attenuated vaccine given subcutaneously, costs about 2000 rupees. All adults, all healthcare workers, they should get it. If they did not get this vaccination in the childhood, or they did not have chickenpox, we should advise all the contacts of herpes zoster ophthalmicus patients that they should get this vaccine. Within 3 days, 70% protection, within 5 days, 50% protection can be there. And to prevent herpes zoster, another type of vaccine is used which is called shingle vaccine or the zoster vaccine. We must think that the virus is the same, but the vaccine is different. Shingle vaccine is not available in India. 2 doses are given above the age of 50 years. Till that time, we can give varicella vaccine. Tdap. Many of us may not have heard the name of this vaccine. Tdap contains full dose of tetanus and reduced doses of diphtheria, and acellular type of pertussis vaccines can be used in persons above the age of 7 years. When we were students, we were told that DPT vaccine should not be used in above 5 years. But now this is a different vaccine. Tdap is given every 10 years up to the age of 65 years. If one is not sure of early vaccination, then second dose of TD can be given. Second and third dose of TD can be given. And each pregnancy, 1 dose of Tdap must be given. All the staff of the maternity homes and children hospital, they must get this vaccine, including Safai Karamchari, including the clerical staff. Coming to painful vaccines, when the pertussis component is whole cell pertussis, this is painful, causes more side effects. While acellular type of pertussis component that causes less side effects, it is called painless. Rabies vaccine. All of us should get this vaccine pre-exposure, because these vaccines are not available in every city, every shop, and moreover the antibodies, they are not available everywhere. So if you have got this vaccine pre-exposure, then only 2 doses are required after exposures with no need of antibodies. All healthcare worker and animal handler must get this vaccine pre-exposure. Post-exposure 5 doses are used plus antibodies for class 3 bites. Coming to human papilloma virus vaccines, currently there are 2 types of vaccine, 4-valent and 9-valent. The 2-valent has become obsolete. After the development of 4-valent vaccine by Serum Institute of India, the Cervavax vaccine had disappeared from market. This prevents cervical, genital, oral, head and neck cancers and genital warts. This will be available in the national immunization schedule after a few months, maybe April or June. The government of India is buying 16 crore vaccines for this purpose. Cost of Gardasil 4 is 3,000 rupees and Gardasil 9 is 8,500 rupees. 9 to 14 year 3 doses, and above 14 year 3 doses. 3 doses are used. 9 to 14 year 2 doses are used. In each pregnancy, Tdap is a must. This can be followed by, or this can be preceded by, a dose of TD. Besides that, flu vaccine should be given in pregnancy. Coming to summary, for preconception period or adolescent, whether boys or girls, MMR, MRR vaccine, flu vaccine, typhoid, hepatitis A and B, varicella, human papilloma virus, and Tdap. And coming to adult 20 year, 30 year, 40 year, 50 years, typhoid conjugate vaccine once only, flu vaccine every year, PCV 13 after 50 years, PPSC after 65, plus with person with comorbidities, varicella 2 vaccines, hepatitis A killed vaccine 2 doses, live vaccine single dose, hepatitis B, MMR, Tdap, zoster, rabies, human papilloma virus vaccine, and Japanese encephalitis. That is used only in endemic areas. In special situations, cholera vaccine, yellow fever vaccine, and meningococcal vaccines can be used, especially those who had physiological or anatomical splenectomy. Thank you. Thank you, sir.
Thank you, Professor Taneja. It is very enlightening because first we have to protect ourselves, then only we have to think our patient. So those who are not taking the vaccine and at their proper time, please be sure that you should take it now itself.
If you have any question about any vaccination, even corona vaccination, pediatric vaccination, you can ask me. Anytime, later also. Thank you.
Do you have any experience about the corona vaccination? Because lots of patients are asking still that they have problems taking corona vaccines.
Sir, actually, corona vaccination topic has been almost finished now because the corona epidemic is not there right now in the country. Only 2 days back, there were 185 cases in our country, new cases, out of 2 lakh tests done. So, most of the people, they may say that they have side effects of vaccine, but actually most of the people in our country, about 95%, they have got corona. When you give vaccine, this is a small dose only. When you get corona, in herbs the viruses are produced, and the effects are because of the corona, not due to COVID vaccine.
Any question from anyone? Thank you, sir. This Pandey is here? Yes, sir. Yeah. So next topic will be importance of counseling patient in high volume tertiary eye care center. This is very important because until and unless we do proper counseling, the satisfaction level and other things will come up. So the counseling part is very important. Let's welcome Dr. Deshpande for this important topic.
Thank you, sir. Thank you, Chairperson. Today I will be talking about the importance of counseling. As sir has already highlighted the importance of counseling to be done. What is counseling? Counseling is a specialized, it is a non-clinical activity that involves giving information, explanation, guidance, and providing comfort to the patient. Counseling helps in providing verbal information, explanation about their disease, guiding them in making decisions with regard to various treatment options available. Objectives of counseling are reduce workload to the doctors and MLOPs, ensuring patient satisfaction and compliance, increasing patient volume. Ideal model for counseling is moderate educated female from rural area are the best suitable candidates in a high volume community based eye hospitals. Candidates who successfully complete a 2 years training course are also appointed as counselors, and to my knowledge doctors are the best counselors. The various roles of a patient counselors is a guide, companion, information giver, facilitator, help in decision making, negotiator, supporter, comfort, link between a doctor and a patient, between the families. Quality of a good patient counselor is that the bright and pleasant look, willingness to serve old and visually handicapped patients, clarity of thoughts, simple and clear communication of information to the patients, compassion and kindness regarding patients and patient care, basic knowledge in ophthalmology and sympathy towards patients. So these have the qualities that has to be inculcated in them. Then the type of counseling, you come to it is a individual counseling, it is a group counseling and the family counseling. Advantage of individual counseling is counselor is individually sitting with the patient and doing the counseling with the patient or the relatives. Personal attention is there, patient feels free to talk because patient alone is in the room along with the counselor. Patient's acceptance level is very high. Sometimes patient, they have apprehension in their mind and they may not open up in the fora or in many people. So in one-to-one counseling, they can open up and they can ask their queries. So patient satisfaction level is high. Advantage of a group counseling means, suppose some sort of a post-operative information we want to give to patients and it is common to everyone, then we gather the patients and then in group we do counseling. So that is known as a group counseling. Shy patient is motivated to interact in such group counselings. Direct dialogue may be there. Then patient fear psychosis is reduced. A member of group who has not understood that the counselor has said can clarify doubts from another member. Now suppose some counselor says something and the patient is not able to understand, but patient can ask to other patient who is there in the room. So the patient can reciprocate what has been told by the counselor. Now family counseling means there are two parts, some genetic counseling and grief counseling. Genetic counseling is done in certain cases like retinitis pigmentosa, then RP, retinitis, these retinoblastoma cases and all. So this genetic counseling is there done for the consanguinity, consanguine marriages and all other problems they can crop up. Then the grief counseling, suppose if patient develops some infection or some problem post-operatively or sudden death in the hospital, so that is a grief sort of a counseling that has to be done to the patients and meticulously to understand the patient's problem and psychology. The art of counseling is different. Body language, listening, voice modulations and all important. Body language, frequently the counselor has to be cool, calm, the direct eye-to-eye contact. When you are counseling, you should not look at the mobile or see somewhere and do counseling. You should have direct eye-to-eye contact, relax body postures and friendly gesture. Then listening, two aspects, hearing and understanding. So listening is also very important in counseling. What patient says, the counselor has to listen. Then the good characteristics of a good listener. So these are, the carries out the appropriate need and wishes, expresses word of sympathy and shows respect and interest. Then the voice modulation, depending on the situation, the counselor should modulate her or his voice according to the an appropriate body language with the patient. Then barriers of communication are misinterpretation. Patient have a wrong notion of laser is a dangerous procedure, or some myths they are there in patient's mind. Then the age and uneducated patients, aged patients may not be interested in details. Language problems sometimes. Then patients may interrupt during the course of the counseling and distractions, some phone calls or some talks, something like that. Then overcoming the barriers, what to inform. So these are the various ways how we can overcome the barrier by estimating cost, post-operative guidelines, detail about the causes of the diseases. Now certain analogies are also used in counseling, like some examples are given, like traveling by train and traveling by a flight analogy. Patient may ask which type of lens, what is the difference between this lens and that lens. So some sort of the analogy can be used, or walking stick analogy. Then the tips of the good counselor: be relaxed, attentive, learn forward while talking, keep facial expressions, look pleasant and genuine. Setting up of a counseling room, a room has to be there, quiet and peaceful. Chair, table should be there, computer, sufficient distance between the patient and the counselor. So various counselor aids are there. They are the models which we can do counseling: laptops, booklets and albums. So counseling in community, I think the time is up, so I will not go in more details about it. So coming back to the main carry home message in counseling is very important part, integral part of our treatment. If you can see patients, you can diagnose diseases, you do surgeries, but if you're poor in counseling, again the services, you may distract you, or the patient may not get satisfaction. So in order to have a direct dialogue with the patient, pre-operative, some myths are there in patient's mind, post-operatively something has to follow, and the outcome of surgery is suppose not predictive. So this counseling really helps and clears the doubts between the patients and the doctors. Thank you very much.
Thank you, doctor.
Yes.
The most important part is that we cannot rely on the counselor itself, because sometimes doctor is the best counselor and patient usually believes on the doctor.
Yes.
So this is the most important part. Another part is that if everything goes all right, that's all right. But
Yes.
if something goes wrong,
Yes.
then only the problem comes. That's why we have to be prepared that everything should be counseled properly.
Yes,
properly
yes.
beforehand.
Thank you, sir. Thank you very much.
So we are welcoming Dr. Alaka Jha here, co-chairman of this session. So next.
I invite Dr. Indramohan Rastogi from Gurgaon. He was main organizing secretary at Gurgaon 2020. I was organizing secretary.
Thank you, sir. Good evening, good afternoon all. Importance of medical documentation. The last few years, our society has changed a lot. Whether we have changed or not, or just forget our old teachings, that has to be seen. These days, mistrust in society for the doctors is increasing. Everybody knows about the isotine drops also. Mobocracy is the problem. Multinational healthcare has come into the play. And main thing is lack of communication or the poor communication. And then another factor which is upcoming is problem with the medical fraternity. The most important thing is poor record keeping. When we are, in trouble, we look into the records, and that is the important thing. Yellow journalism, when we are short of records, when we have to defend ourselves, journalism comes into the play. So that attitude of the society, which is towards the doctor, has to be changed, and we have to be very much, into the records. Where healers will remain the same, but the thing is record keeping. Concept of family physician is changing. That days is gone. Yes, we have to be empathetic towards the patient, but we have to be very much into the up-to-date in records. And rather it has become a science itself. So importance is that comes into standard of care for the patient, for the institution, legal protection, for the doctor, and above all the ethical. Poor record means poor defense in the court of the law. No records means no defense, you are caught. Purpose of the proper records is patient care, communication with the patient, and further treatment. Days of TPA, so billing and reimbursement is of utmost importance. If records are not proper, claims will not be proper, patient will be, will not come to you back. And about research and quality management, that is the another thing. So legal documentation system relies on the documentary evidence in a situation if medical negligence is there. Medical documentation consists of all these things: electronic health records, physical examination, consent forms. Just now Dr. Deshpande has said. And these days, just now, even AIOCMTC has come into the consent forms in local, regional languages. When we are doing operative things, we have to put the time as well as, every person who is there into the OT. So safety starts with us only. All important documents, even investigations, discharge, instructions, discrepancy in the summary given to the patient in the hospital record, that always causes a suspicion. And that is, in the court of law, is tampering with the medical records. An undated prescription, if it is in the hand of the patient and it is goes into the legal system, if the prescription is undated, it can trouble, put the doctor into the trouble. Again, when we are doing referral, we have to put everything on the referral note. We, as by law, we have to keep the duplicate copy of the referral note with the patient's signature, that at this time I was advised to go, this time I was referred, and if something happens, wrong happens, only that document can save the doctor. We have to keep the confidentiality of the records also. These days, illegible handwriting is again, not taken in the court of law. As far as any kind of the surgery is concerned, if we are caught, we should have video recordings of our IOL surgeries and all that. Electronic health charts, ECG records, everything that has to be there. And that all helps in the patient management. So onus lies on the doctor, and who is at the pivotal role for the nurses, medical staffs and all that. So good medical record is which is accurate, accessible, comprehensive, consistent and timely updated. The issue of medical record keeping guidelines is maintain indoor records for 3 years, and if somebody asks for any kind of the copy or anything, that has to be supplied within 72 hours. Any kind of certificate, if issued, that has to be it should be duplicate copy should be there. So it is advisable to maintain outpatient records, even OPD records for 2 years, and for 3 years for indoor. And in pediatric cases like ROP cases and all that, we should have the records till the child attains the age of the maturity. And in death cases, records has to be kept permanent. And if the case is sub judice or in the medical record, that has to be kept till case is over. So by and large, medical records are the property of the hospital, and it is the responsibility of the hospital to maintain it properly. Records should be always in the safe custody. An unsigned record has no value. Failure to provide medical records to patient on proper demand is always a deficiency in service and negligence. Medical records, they are summoned in the court of law. These are various courts of law where the records can be required. And the policy for disposable is, once the time period is over as prescribed, indoor, outdoor and all that, they has to be disposed as per state policies, either by shredding or pulping, and the person who is destroying, who is helping it, that all has to be kept under documentation. So proper documentation both in the patient medical records and in claims is important to protect the doctor, to protect the institution and to protect your patient. Complete and accurate medical record keeping help you ensure that your patient gets the right thing at the right time and you are saved always. Remember, you have to be precise, you have to be up to date, and you have to be descriptive in your records, come what may. Thank you very much.
Thank you, Dr. Indramohan. We have with us Professor BNR Subudhi.
Thank you, sir.
Sir, he will present his talk, Ophthalmology of Universal Eye Care, for Universal Eye Care. Dr. Sumit Grover.
I'm sorry, I was held up in the OPL. So OPL ran up to 3:30. Thank you, our chairman and convener moderator, for allowing me in the middle of the session. My topic is teleophthalmology for eye care at the doorstep. So I thank AIOS midterm conference and LOC for giving us the opportunity to speak at this venue. Why do we need eye care at the doorstep? As you know, the blindness is a challenge. 45 million in India are visually handicapped, 12 million totally blind, and 1/4 of the world's population, blind population, live in India. Majority of them are needlessly blind, and 80% in rural areas. So we speak about the universal care for everybody. Are we doing that? Because patients are many and located at various locations, equipments and instruments are limited, and doctors are even more limited. So what are the issues for eye care in India? Shortage of doctors. Yes, it's a very important thing. India is one among the countries which suffer from a shortage of doctors. There are only about 20,000 ophthalmologists, or more than 20, just about 25,000 ophthalmologists in India, with most concentrated their practice in the urban localities. And additionally, the infrastructure of our rural areas like roads, telecommunication, transport, and financial status of the patients is very deficit. So it makes it more difficult to provide health care to the people in the rural areas. Eye care, particularly the remote areas, it's very difficult. You know, India is a country with diverse cultural heritage. The geographical location, like remote and tribal areas, play a critical role in delaying the diagnosis in the early stage of the disease, causing needless blind. So you know that these are the areas we serve. We belong to this type of areas in many of the states. And in India, there are about 1 ophthalmologist per 1 lakh population, and 80% of them live in the urban areas only. And 80% healthcare resources in urban areas available, but 80% of the people are living in the rural. There's a disproportionate in the healthcare and the people living in the rural areas. Advancement in technology, as the technology is advancing, we have to go with advanced technology. So in the recent, there has been exponential growth in information technology and its impact on all areas, including the medical fields, where accessibility is a major problem because of the inaccessible roads. In order to make eye care services accessible to everyone, the concept called teleophthalmology has come into the picture, and more so during COVID times. So teleophthalmology allowed clinicians to provide quality healthcare outside the clinics through digital technology, thus improving the access to medical care, patient outcomes, and overall patient satisfaction. So this is the teleophthalmology concept. A van well equipped with all the portable instruments goes to the rural areas where either doctor or paramedics take the photographs, and they transfer the images to the people sitting in the urban areas or health centers, basically secondary health centers and tertiary health centers. They interpret the image and immediately transfer and they dictate the treatment to the people sitting in the rural areas. So mostly these are the instruments we utilize for the portable examination of the certain diseases like diabetic retinopathy. Everybody knows a portable fundus cameras are available, where AI incorporated in the photographs. In glaucoma also, there is portable tonometer, portable perimeter is available. Refraction, of course, there are portable refractometers are available where you can take the refraction reading and you can prescribe the glasses then and there at the rural areas. And of course, glaucoma and even cataract can be diagnosed through the teleophthalmology. So teleophthalmology enables a doctor from one end to interact with the patient sitting at the distant, remote and a far away place, very unreachable place, either by video conferencing or by data sharing through the computers. Diagnose the patient with the help of a local doctor, and MBBS doctor can do that, even other AIOCMTC doctors can do that. Optometrist, ophthalmic assistant, a trained health worker, if a +2 pass person can be trained how to handle these instruments. He can take photographs and they can transfer the instrument, the photographs to the people sitting in the urban areas. So teleophthalmology, all these conditions of ophthalmology can diagnose the disease in early stage like adnexal, orbital disease, lead, conjunctival corneal disease, diabetic retinopathy, glaucoma, age-related macular degeneration, retinopathy prematurity. You must have learned about the kid drop from Karnataka. They are doing wonderful for the treatment of ROP patients in the country, refractive errors, emergency post-operative follow-ups. So objectives of teleophthalmology is to make eye care services available and accessible by the reducing travel cost and the time for the patients, and to enable the people at remote areas to have the access to specialized eye care services which are available for the only urban people. So these are the advantages of teleophthalmology: our extensive outreach, avoiding unnecessary referrals, health education, timely intervention in emergency situation, saves cost, time and effort, and professional opinion. Lastly, but not least, the protection against infection, which is COVID infection. It was there during COVID times. So I would like to give a message to the people sitting here that teleophthalmology is the only solution for patients who would otherwise not have access to an eye care professional to be screened and treated earlier by their doorstep by the paramedics to prevent permanent visual complications. So we are only 20-25 the ophthalmologists. The paramedics, about more than 40,000 paramedics are available, optometrists, doctors. So let us utilize them. Let us train them how to take the photographs of various eye diseases, and then they can transfer the data to us and we interpret and treat them. So through teleophthalmology, all the urban treatment, the modern treatment of ophthalmology can reach the rural people for which we are working. So universal eye care, the teleophthalmology is the only solution for the universal eye care which can give each and every individual of the country, which unless they become needlessly blind. So for which we have formed the Teleophthalmology Society India. It was born during the COVID times, 1 year back. It's growing slowly. And I request all of you to become this member and reach our hands, enhance our technology to the rural areas. Now the 5G have come, there's a faster delivery of the images to the urban areas. So please come forward and be a member. Already there is a website, the tosi.org.in. Please go into the website and give your membership money through the online. So thank you very much. Last but not the least, a small appeal to all of you. I am contesting for the post of editor proceedings. Please help me in getting this editor proceedings in the AIOC election 2023. So thank you very much for the patient listening. Thank you, judges, giving the opportunity once again.
Thank you, sir. Dr. Sumit Grover. So he has not come. So anybody wants to ask any question on any of the topics presented by various speakers? So I am extremely thankful to person on the dais as well as all the delegates. Extremely thankful to Dr. Milind Kumar, LOC member. He is here to listen to us. All the presenters, please come forward for a photograph. आ जाओ मिलिंद भैया, आ जाओ, अभी आ जाओ. अरे आइए सर, हमारा सौभाग्य है कि आप हमारे सेशन में आए. एक मिनट बस उसको लेने दो, एक मिनट.